Good good day everyone. So thank you Sir Zam for this PowerPoint. So welcome to your pharmacology class once again. Today we're diving to a very important topic which is GI drugs or your gastrointestinal drugs. But before we begin, let's take a moment to understand why studying this subject is crucial to your future profession as pharmacist. So, as pharmacists, we all know you will play a vital role in patient care, ensuring the safe and effective use of medication. So, the GI system is an incredibly complex and delicate part of the human body. It is responsible for the digestion and absorption of nutrients as well as the elimination of waste no, in the human body. So, disorders and diseases affecting the GI tract are prevalent and can significantly impact a person's quality of life. So, GI drugs encompasses a wide range of medications designed to treat various conditions such as very common your acid reflux, no mga ulcers, inflammatory bowel disease and many others. So, by studying these GI drugs, you will gain the knowledge and skills needed to identify these conditions, understand their underlying mechanisms, and provide appropriate treatment options to your patients. Understanding the pharmacokinetics, mechanism of actions, and adverse effects of GI drugs is crucial to ensure optimal patient outcomes. So, you will learn about different drug classes such as PPIs, very common, your proton pump inhibitors, H2 blockers, antacids, laxatives, and antiemetics, among others. So, by mastering this knowledge, you will be able to make informed decisions, collaborate with healthcare professionals, and guide patients towards the most suitable treatment options. So, since finals na nino, remember as future pharmacists, you will be the experts when it comes to medications. Your patients will rely on your expertise and guidance to manage their GI conditions effectively. So, your understanding of GI drugs will empower you to provide personalized care, offer valuable advice, contribute to improving the health and well being of your patients. So, today we will be discussing the pharmacology of the GI system. So, we'll start by exploring the pathophysiology of GI disorders, which includes conditions like your GERD, your gastroesophageal reflux diseases, ulcers, and various issues affecting the esophagus, stomach, and duodenum. Next, we will also delve into the drugs used to treat ulcers. Ulcers can be a result of several factors, including bacterial infection and excessive acid production. To combat these ulcers, we have antibiotics, proton pump inhibitors, histamine 2 blockers, antacids, and combination therapy. We will explore how these medications work and their specific roles in treating ulcers effectively. Moving on, we will examine drugs used for motility disorders of the GI system. So, these disorders can disrupt the normal movement and function of the gut, causing symptoms like nausea, vomiting, and irregular bowel movements. So, to address these concerns, we have a range of pharmacological interventions available, such as prokinetic agents, antiemetics, antispasmodic, laxatives, and antidiarrheal agents. We will learn how these. Sorry. We will learn how these medications help regulate gut motility and alleviate symptoms. So, the drugs used for GI disorders encompass a variety of medications targeting specific conditions. Let's explore some of these drugs. So, first are drugs used for acid peptic disease. This category includes antacids, your H2 blockers, proton pump inhibitors, now very common, your omeprazole, mucosal protective agents such as your sucralfate, misoprostol, and bismuth compounds, and antibiotics. These drugs help reduce gastric acid secretion, protect the gastric mucosa, and treat conditions like GERD and ulcers. Next are your motility promoters, metoclopramide and sorry, cholinomimetics are examples of drugs that enhance your, excuse me, GI motility. So they help regulate your gut movement and are often used in conditions like gastroparesis and mura man kog ako nagki-GERD karon gyud lately. They help regulate your gut movement and are often used in conditions like gastroparesis and post-op ileus. Next is your drug for IBS or irritable bowel syndrome. So, anticholinergics and serotonin antagonists are commonly prescribed for IBS. So, they help alleviate symptoms such as abdominal pain, mga bloating, and altered bowel habits. Next are your drugs for inflammatory bowel disease. So, these are conditions that includes your Crohn's disease and your ulcerative colitis. So, kanisha, they may require a specialized approach. So, treatment options would include your 5-ASA drugs, corticosteroids, immunosuppressants, and anti-TNF drugs. So, these medications help control inflammation and manage symptoms. Other agents, your pancreatic lipase supplements aids in the digestion of fats, while laxatives and antidiarrheals help regulate bowel movements. Ursodeol is used to dissolve gallstones and it also has hepatoprotective properties. Next are your antiemetics. These drugs target nausea and vomiting. Examples your 5-HT3 blockers such as ondansetron, D2 blockers such as your chlorperazine, H1 blockers such as your diphenhydramine, antimuscarinic such as your scopolamine, corticosteroids such as your dexamethasone, cannabinoids such as your dronabinol, and uric receptor antagonists such as your aprepitant. Okay, so explore first the diseases. So first is your peptic ulcer disease. So your peptic ulcer disease involves the formation of ulcers in the lining of the stomach or the upper part of the small intestine or your duodenum. So what are the characteristics of duodenal ulcers and gastric as well as GERD? So first is your duodenal ulcers. So your duodenal ulcers are the pain would be relieved by pagkatapos mong kumain, no, na-relieve yung pain. The discomfort or pain associated with the ulcers will tend to improve after eating, occurs 2 to 3 hours after a meal. Ako nagiging GERD. Symptoms typically manifest a couple of hours after eating. So, this is the most common type, and duodenal ulcers are more prevalent than your gastric ulcers. So, here, it will manifest as melena. So, melena refers to super black tarry stools that result from bleeding in your upper GI tract. So, the more na siya sa upper GI tract, like your stomach, no, when you look at the anatomy, the more na bas dugay magawas ang tae, so the more bas black mo represent ang blood. That's why pag upper GI na problema like your like your duodenal ulcer, so bas black ang manifestation sa blood kay bas dugay na siya dito. So that's what we call your melena. Next is your gastric ulcer. Gastric ulcers, pain would be increased by a meal. Eating exacerbates the pain experienced with gastric ulcer. This occurs 30 minutes to 1 hour after a meal, and symptoms typically arise within half an hour to an hour after eating. This is not as common. Gastric ulcers are less common compared to duodenal ulcers. So, vomiting occurs. Nausea and vomiting may accompany gastric ulcers. One of the things you must also know is your GERD, no, very common. This is characterized by inflammation or irritation of the esophagus caused by the backflow or the reflux of your stomach acids, no. Mo na siyang ginatawag natin na heartburn. So, yung ma-acidic contents galing sa stomach mo, naga-regurgitate or nagapasa ka siya, no. Moto, no, so katong acid sa imong esophagus, ang lining sa esophagus is not made sa unsa ka acid ang imong stomach. So pag magsaka ang content sa imong stomach sa esophagus, no, madaot to kay magka burn siya. So that's why it leads to discomfort and a burning sensation sa patient, no. Okay, so now we're going to delve into your antacids. So, antacids, they are commonly used to alleviate symptoms of heartburn and indigestion by neutralizing the stomach acid. Let's explore the different types of antacids and their associated adverse effects. First is your sodium bicarbonate. They react rapidly producing carbon dioxide. Sodium bicarbonate quickly reacts with stomach acid, resulting in the release of carbon dioxide gas. They are absorbed in the gut. It is absorbed through the GI tract into the bloodstream. Adverse effects would include your belching, flatulence, metabolic alkalosis, rebound acidity, and fluid retention. Next is your calcium carbonate. They are react more slowly. Calcium carbonate takes longer to neutralize stomach acid. They are absorbed in the gut. It is absorbed through the GI tract. Adverse effects include your belching, flatulence, metabolic alkalosis, and there is a potential risk for kidney stone formation with long-term use. Next is your aluminum hydroxide. There is no carbon dioxide production. Aluminum hydroxide does not produce carbon dioxide gas upon reacting with stomach acid. They react slowly. It has a slower reaction rate compared to other antacids. This is not significantly absorbed. Aluminum hydroxide is minimally absorbed into the bloodstream. Adverse effects can cause constipation and may lead to aluminum toxicity with prolonged use. Magnesium hydroxide, no carbon dioxide production. Magnesium hydroxide reacts slowly. It has slower reaction rate, similar to aluminum hydroxide. No, this can cause diarrhea, magtae due to its laxative effect. So these antacids, they work by neutralizing your stomach acid, providing relief from symptoms associated with excess acidity. So, your H2 receptor antagonist are a class of medication. I don't know what's wrong with the picture. They work by blocking the histamine H2 receptors in your stomach, leading to a reduction in gastric acid secretion. So, this inhibition of histamine, which is a potent stimulus for acid production, results in decreased acid levels in the stomach. So, H2 receptor antagonists are commonly used in the treatment of various acid-related conditions such as your peptic ulcers, GERD, and certain cases of hypersecretory disorders like your Zollinger-Ellison syndrome. So, first is we have your cimetidine. So, this is a receptor antagonist that also acts as an enzyme inhibitor. While it effectively reduces gastric acid secretion, it has been associated with certain side effects. In men, it may cause gynecomastia or enlarge yung breast tissue and impotence, while in women, it can lead to galactorrhea or abnormal milk secretion. Next is your ranitidine. It's used in the treatment of acid-related disorders. It is generally well tolerated and it has lower incidence of side effects compared to your cimetidine. Next is your famotidine. This is considered the most potent H2 receptor antagonist among the class. It effectively reduces gastric acid secretion and it is widely used in clinical practice for various acid-related conditions. Next is your nizatidine. So nizatidine is a newer H2 receptor antagonist that is unique as in being the only non-hepatotoxic member of the class. So it provides effective acid suppression and is considered a safe option for patients with liver impairment. So next is your proton pump inhibitors. So these are a class of medications that work by binding covalently with your hydrogen potassium ATPase enzyme in the gastric parietal cells. No, this enzyme is responsible for the final step of your gastric acid secretion. So that's why you inhibit them. So let's explore some of your PPIs. First is your omeprazole. So omeprazole is a widely used PPI that effectively reduces gastric acid secretion. So it is used, no, mo ganin siya ang libre sa health center. So kasi mura lang din siya. It is available in various formulations. So next is your lansoprazole. It's another commonly prescribed PPI that inhibits gastric acid secretion. No, it is available in different forms including delayed release capsules and orally disintegrating tablets. Your rabeprazole is It still inhibits your acid production. This is available in enteric-coated tablets for oral administration. Pantoprazole, it is available as delayed release tablets and IV formulations for both oral and parenteral administration. So wards in the hospital, no, we just use um naging common ng pantoprazole. Esomeprazole is a more recent PPI that is the S isomer of omeprazole. It exhibits a higher degree of acid suppression and is available in various formulations, including delayed release capsules and IV formulation. So next is we have your GI protectants. So first is GI protectants are medication used to help protect the GI mucosa and promote healing in certain conditions. So first is your sucralfate. So your sucralfate is a GI protectant that works by polymerizing in the acidic environment in the stomach. So this forms a viscous gel-like substance that binds to ulcer, providing a protective barrier. It accelerates the healing process and helps reduce the recurrence of ulcers. We also have your misoprostol. So your misoprostol is a synthetic prostaglandin E1 methyl analog. It stimulates the secretion of mucus and bicarbonate, which helps protect the gastric mucosa and maintain the integrity of the stomach lining. Next is your colloidal bismuth. Colloidal bismuth compounds such as colloidal bismuth substrate have protective properties for the GI mucosa. They can coat ulcers, providing a physical barrier, and also stimulate the effects of prostaglandin and mucosal protection. And they also have antibacterial properties or effects against certain bacteria such as H. pylori. So, antibiotics. The ulcer-causing gastric pathogen H. pylori is the only bacterium known to colonize bisag acidic na kain na imong stomach. So why? No, they survive in the acidic condition by producing urease, which catalyzes hydrolysis of the urea to yield ammonia, thus elevating the pH of its environment. So when it comes to the treatment of ulcer caused by H. pylori, antibiotics plays a crucial role in eradicating the bacteria. So there are several drug regimens that are commonly used for the purpose. So let's explore some of them. So you have your PPI plus bismuth subsalicylate plus tetracycline plus metronidazole. This regimen usually use PI tetracycline. Yeah. So si bismuth subsalicylate, they provide a protective coating, tas meron pa din siyang antimicrobial effects. Well, your tetracycline and metronidazole, no, they are the antibiotics na nag-directly kill sa bacteria. So, number 2 is you have your PPI plus bismuth subsalicylate plus tetracycline plus metronidazole. Similar sa previews, pero different yung frequency, no? So, 4 times a day yung first, while ito is not. Okay, next is we can also use clarithromycin plus PPI plus amoxicillin or metronidazole minsan. No, this is considered actually the first line therapy for H. pylori eradication. So, twice a day yan. So, constipation is a condition characterized by decrease in the frequency of bowel movements and difficulty in passing stools. So, to address constipation, various treatments options are available, with laxatives being commonly used. Laxatives are medications that help promote bowel movements and relieve constipation. So, next is we have your bulk-forming laxatives. These laxatives work by adding bulk to the stool, which helps stimulate bowel movements. They contain fiber and other substances that absorb water, making the stool softer and easier to pass. This includes your psyllium husk, methylcellulose, and polycarbophil. So next is your saline and osmotic laxatives. Saline and osmotic laxatives are a type of laxative that work by increasing the liquidity of stool throughout the colon. They achieve this by increasing the concentration of solutes in the intestinal lumen, which leads to water retention and softening of the stool. So we have your sodium and magnesium salts. Um, so magnesium hydroxide, no, commonly known as the milk of magnesia, and magnesium citrate are examples of saline laxatives. They work by drawing water into the intestines, increasing stool liquidity. These laxatives should be used with caution in patients with hypertension, congestive heart failure, and renal impairment. Kaya pwede siya ma-worsen, no? Next is your glycerin osmotic laxative that comes in the form of suppositories or enemas. So how do they work? They attract water into the rectum, stimulating bowel movements. So glycerin suppositories are commonly used for occasional relief of constipation. So lactulose is an osmotic laxative that is not absorbed in the small intestine. It passes into colon where it is fermented by bacteria. So this fermentation process increases the osmotic pressure in the colon, drawing nagatawag sila water into the intestines mo nang muhumok imong tae. So lactulose is often used in the treatment of chronic constipation and hepatic encephalopathy. So, stimulant laxatives are a type of laxative that work by directly stimulating the movements of the GI tract to promote bowel movements. They can be effective for relieving constipation but should be used with caution and under the guidance of healthcare professionals. So, we have your senosides and cascara. Senosides are derived from your senna plant, no? While cascara is derived from the bark of the cascara tree. So this substance stimulate intestinal contractions, helping to move stool through the colon. However, no chronic use of this wood can lead to a condition called cathartic colon, which is characterized by a loss of normal bowel movement. It is generally recommended not to use these laxatives for more than 1 week without medical supervision. Pwede na ko ano ba yun siya as tea. Next is ginapalagi as tea. Bisacodil is a stimulant laxative that stimulates the intestinal nerves, causing increased bowel movement. So it is commonly used for short-term relief of constipation. So it is important to follow the recommended dosage and duration of use to prevent dependence on laxative abuse. Next is your castor oil. So castor oil, they work as a stimulant laxative due to the presence of the ricinoleic acid, which has irritant properties. It stimulates the smooth muscles of the intestine, promoting bowel movements. However, castor oil is contraindicated in pregnant women as it may induce uterine contractions and pose a risk to the pregnancy. Next is your emollient laxative. These are also known your stool softeners. They are a type of laxative that work by facilitating the penetration of water and lipids into the stool, thereby softening it and making it easier to pass. They help prevent or relieve constipation without necessarily stimulating bowel movements. So, some of these would be your glycerin suppositories, commonly used as gentle and fast-acting solution for occasional constipation. So they work by attracting water into the rectum, lubricating the stool, and stimulating bowel movements. You have mineral oil, still a lubricating laxative that forms a waterproof barrier in the surface of the stool, preventing water from being absorbed and keeping it soft. It helps ease the passage of stool through the intestines. However, no prolonged use of these may interfere with the absorption of fat-soluble vitamins and can lead to unwanted side effects. No? So, dapat in moderation or medical supervision lang pa rin. Docusate sodium, an ionic surfactant that helps facilitate the mixing of water and fat in the stool, resulting in a softer consistency. So, it is commonly used as stool softener to alleviate constipation. So, safe naman for short-term use, but again, prolonged use should be avoided without medical guidance. Next is your chloride channel activator. So, hold on, give me 2 minutes. Okay, your chloride channel activator is a type of medication used for treatment of mga chronic na. So they work by stimulating the type 2 chloride channels in your small intestine, leading to an increase in chloride-rich fluid secretion. This in turn helps to soften the stool, promote bowel movements, and stimulate intestinal motility. So one example of a chloride channel activator is your lubiprostone. So this is commonly prescribed for individuals with chronic idiopathic constipation or irritable bowel syndrome with constipation. So by activating the chloride channels in the intestine, lubiprostone enhances the secretion of fluid into the bowel, resulting in softer stools and increased motility. So opioid antagonists are a class of medication used to counteract the effects of opioids, particularly in GI systems. So opioids can cause constipation by decreasing GI motility and increasing the absorption of water from the stool, resulting in hard and infrequent bowel movements. So opioid induced constipation is a common side effect of opioid therapy for pain management. So one example of that would be your methyl naltrexone. So these targets peripheral opioid receptors in the GI tract without crossing the blood-brain barrier. It works by blocking the opioid receptors in the gut, which helps restore normal bowel function and relieve opioid-induced constipation. Next is your alvimopan. It's another opioid antagonist used for the management of opioid-induced constipation. It selectively blocks the effects of opioids in the bowel, promoting bowel motility and reducing constipation. Used in hospitalized patients who are receiving opioids for post-op pain management. Okay, next is your adsorbents. These are a type of medication used for the symptomatic relief of diarrhea. They work by absorbing or binding to substances in GI tract, including water, toxins, and bacteria. It helps to firm up the stool and reduce the frequency of bowel movements. First is your kaolin. Kaolin is a natural clay mineral composed of hydrated magnesium aluminum silicate. It has the ability to absorb water and toxins in the intestine, resulting in firmer stools. Kaolin is often combined with other ingredients in antidiarrheal formations. It is important to note that kaolin should be used under the guidance of a healthcare professional and should not be taken within 2 hours of other medication as it may interfere with their absorption. Pectin is an indigestible carbohydrate found in the cell wall of plants. It acts as a natural adsorbent, helping to absorb water in the gut and mag-add ng bulk sa stool. So, pectin is commonly used as a component of your ORS, no? Yung oral rehydration solutions na ginadrink natin. And over-the-counter antidiarrheal products. It may also have a soothing effect on the inflamed intestinal lining. So, opioid agonists are a class of medications used for the symptomatic relief of diarrhea. So, unlike your traditional opioids, these medication do not cross your blood-brain barrier, meaning they do not produce central nervous system effects or analgesic effects. So, first is your loperamide. So, widely used over the OTC medication, no? It works by slowing down the movement of intestines, allowing for increased water absorption and decreased frequency of bowel movements. So, loperamide is available in various forms, including tabs, caps, and liquid formulations. So, it should be used as directed and not exceed the recommended dosage. Next is you have your diphenoxylate. So, it works by slowing down intestinal motility and reducing bowel movement frequency. This is often combined with atropine sulfate to discourage misuse, as atropine sulfate can cause unpleasant side effects when taken in higher doses. So, available in tab form, again, should be used as prescribed, no? Next is your bile acid bending resins. So, these are a class of medications used for the treatment of certain types of diarrhea, particularly those caused by excess bile acids in the intestines. So these medications, they work by binding to bile salts in the GI tract, preventing their reabsorption and promoting their elimination in the stool. So this helps to decrease the concentration of bile acids in the intestine and reduce diarrhea. So first is we have your cholestyramine. So cholestyramine is a resin that binds to bile salts in the intestine. Sorry, wait lang. Okay, so your cholestyramine is a resin that binds to bind salts in the intestine, forming an insoluble complex that is excreted in the feces. So it is available in powder or tablet form and is usually mixed with a liquid before administration. So common as side effects of your cholestyramine includes bloating, flatulence, and constipation. Next is your cholestyramine. This is another bile acid resin that works in a similar manner to cholestyramine. It binds to bile salts, preventing their absorption and promoting their elimination. So this is also available in tablet form and is usually taken with meals. So next is your cholecylamine. This is a newer bile acid binding resin that also acts by binding to bile salts in the intestine. So it is available in tablet form, have a lower incidence of GI side effects compared to the former two. So next is we have your somatostatin. Somatostatin is a naturally occurring hormone that plays a regulatory role in various physiological processes within the body. Um, in of course it includes your GI system. So they exert inhibitory effects on the secretion of several hormones and has diverse actions within the digestive tract. So what are the effects of somatostatin? First, it inhibits hormone secretion. So that includes your gastrin, glycogen, growth hormone, insulin, secretin, pancreatic polypeptide, and serotonin. So by suppressing the release of these hormones, somatostatin helps to regulate their levels and maintain physiological balance. Next, it reduction of intestinal fluid secretion. So somatostatin has the ability to decrease intestinal fluid secretion by inhibiting the secretion of certain hormones and other substances that promote fluid secretion. It helps to reduce the amount of fluid in the intestinal lumen. This can be beneficial in conditions associated with excessive fluid loss or diarrhea. Next, it can slow GI motility and inhibition of gallbladder contraction. So this results in decrease in the movement of food through the digestive tract. It also inhibits the contraction of the gallbladder, which reduces the release of bile into the small intestine. This next is inhibition of your anterior pituitary hormone. Um, Ayan, so maintain ang hormonal balance in your body. So next is your Next is your antiemetics. So these are medications that are used to prevent or treat nausea and vomiting, which can occur due to various cases such as chemo, no, mga motion sickness, inner ear disturbances, or side effects of certain medications. So the process of vomiting involves several interconnected pathways, including higher cortical centers, chemoreceptors, and the vomiting center located in the medulla. So let's explore the mechanisms of action of antiemetics in more detail. First is your chemoreceptor trigger zone. Located in the area post-rema of the medulla, it's responsible for receiving signals from various chemicals in the blood, such as drugs or toxins. So when activated, it can stimulate the vomiting center and can initiate the vomiting reflex. Antiemetics targeting the CTZ work by blocking the receptors in this area, preventing the activation of your vomiting center. Next is your vomiting center, or also located in the medulla. They receive input from various sources, including the CTZ, GI tract, and inner ear. It integrates these signals and coordinates the motor response included in vomiting. Certain antiemetics act directly on the vomiting center to suppress its activity and prevent the initiation of the vomiting reflex. Next is your GI tract, particularly the stomach and small intestine. They contain chemoreceptors that can send signals to the vomiting center. So this can occur in cases of GI irritation such as gastritis or gastroenteritis. So antiemetics targeting the GI tract work by blocking these chemoreceptors, reducing the stimulation of the vomiting center and preventing the vomiting reflex. Next is your vestibular system. So located sa imong inner ear, no? They also maintain balance and spatial orientation. Mo na pag ma-disturb to, no? Kasukaon pod ka. So, antiemetics targeting the vestibular system work by blocking mga receptors dito, no? Para di ka makapil og kasukaon. So, what are those antiemetics? First is your 5-HT3 antagonist, also known as your serotonin receptor antagonist. These are a class of medication used to prevent and treat nausea and vomiting. They specifically target your 5-HT3 receptors located in the CNS and GI tract. So, first is your ondansetron. Ondansetron is a widely used, no, especially sa mga chemotherapy-induced nausea and vomiting. So, post-op, ginagamit po nato ni granisetron, available in oral tabs and transdermal patches. So, para you can provide options for patients who have difficulty swallowing. No, dolasetron, primarily indicated for prevention and delayed CNV associated with chemo. So, both oral and IV available. No? Pero kani siya has potential for cardiac side effects. Palonosetron, newer ni siya na 5-HT3 antagonist with a longer half-life. So, shown effective in reducing nausea in extended period, no? So, kaning mga 5-HT antagonists are typically administered 30 minutes before chemo, no? Pre-chemo siya na meds. So, they can be used as monotherapy or combination with other antiemetic medications such as your corticosteroids or NK1 receptor antagonists, depending on race of patients, no? So, next are your H1 blockers. So, your H1 blockers, also known as antihistamines. Wait ko, lang ko ng more water. Next is your H1 blockers, also known as your antihistamines. They have various therapeutic uses, no, including management of motion sicknesses. So first is your meclizine, commonly used, works by reducing the excitability of the inner ear labyrinth and inhibiting vestibular stimulation. Available OTC, no, cyclizine, oral ni siya, no, napoy non-drowsy option for individuals to prone to motion sickness. Dimenhydrinate, common drug that contains diphenhydramine and 8 chlorothiophyllene. It is commonly marketed under the brand name Dramamine, and it's widely used for motion sickness. So, diphenhydramine, also known as Benadryl, first gen H1 blocker used for antihistamine properties. So, of course, we know diphen can cause drowsiness and sedation. So, not preferred choice siya. Promethazine is used in pregnancy, used by NASA for space motion sickness due to its effectiveness in reducing symptoms associated with altered gravity environments. So next is your muscarinic antagonists and cannabinoids. So they are used for still for nausea and vomiting. So first is your anticholinergic, your scopolamine. It's an this is available as a transdermal patch, which delivers a controlled release of medication over a specific period. So the patch is usually applied behind the ear. So if you love K-dramas, no, K-Korean shows, tas pag nag-shoot sila outside sa dagat, di ba na may sa mag-fishing, you can see actually scopolamine patches behind their ear. So this can help alleviate symptoms of nausea and vomiting associated with motion sickness. Your cannabinoids, compounds that interact with the endocannabinoid system in the body, they have shown effectiveness in managing nausea and vomiting in certain situations. So, um, what cannabinoids? So, first is your dronabinol, synthetic form of your THC, no, which is the primary psychoactive component of cannabis. So it is available in oral capsule indicated for treatment of chemotherapy induced nausea and vomiting. Next is your nabilone, other synthetic cannabinoid that is structurally similar to THC. It is also available as an oral capsule and useful for the management of chemotherapy induced nausea and vomiting. Okay, next is your dopamine D2 antagonist. So, drug available is your metoclopramide. Pirmigit ko, makuan. Your domperidone. So, both drugs are also prokinetic agents due to their 5-HT4 antagonists. No? Meto is available in both oral and IV. And meto can cross the blood-brain barrier, but domperidone cannot. Okay, this is important that you know the difference between your ulcerative colitis and Crohn's disease. So these are two types of your IBDs. So ulcerative colitis is a chronic inflammatory condition that primarily affects your colon and rectum. So it is characterized by inflammation and ulceration of the inner lining of your colon. Symptoms of ulcerative colitis may include abdominal pain, bloody diarrhea, and urgency to have bowel movements and weight loss. So the exact cause of your ulcerative colitis is unknown, but it is believed to involve an abnormal immune response. While your Crohn's disease is still a chronic inflammatory condition, pero from the mouth to the anus na siya. It involves inflammation, may include abdominal pain, diarrhea, fatigue, weight loss, and malnutrition. Not fully understood pa rin ang cause, but it is believed to be a combination of genetic, environmental, and genetic and immune factors. So, what are treatments? Your aminosalicylates, your 5-ASA agents. We use these to treat your IBDs. So, first is your mesalamine. It's the generic formulation of 5-ASA. It works by regulating the inflammatory process in the GI tract. So, available in various forms, oral caps or rectal formulation. Next is your Pentasa. Pentasa is a mesalamine formulation that contains time-released microgranules. So the microgranules allow for a controlled release of the medication throughout the GI tract, ensuring prolonged exposure to the inflamed areas. Asacol is another 5-ASA formulation that comes in the form of coated tablets. The coating contains a pH-sensitive resin that remains intact in the acidic environment of the stomach but dissolves at a pH of 7 or higher, such as in the colon. So this allows for targeted delivery of the medication to the colon where it is needed. Next is your Lialda. Utilizes a pH-dependent resin system. It consists of a multi-matrix core that contains mesalamine surrounded by a pH-dependent resin. So similar to Asacol, the resin containing ensures the release of medication of the colon. Next is your Roasa. So this is for Rectalina. Canasa is also a suppository that is inserted rectally. Next are your glucocorticoids, no? So, pampakalma ng So, hydrocortisone, synthetic form of your cortisol, no, it has potent anti-inflammatory properties para mag-reduce ang inflammation. Budesonide, we use this no for the orthopedic patients. This is a synthetic corticoid structurally similar to cortisol. It is often treatment for Crohn's disease because it is a high first pass hepatic metabolism leading to reducing systemic exposure compared to other glucocorticoids. So this means that budesonide has more localized effect within your GI tract, minimizing systemic side effects. So budesonide is available in oral capsules which are designed to release the medication in the ileum and ascending colon. Next is your purine analog. So specifically your azathioprine, no? Azathioprine is an immunosuppressive medication that is converted into its active form, your 6-mercaptopurine in the body. So this works by inhibiting the proliferation of immune cells, particularly your T cells, which play a role in the inflammatory response seen in IBD. So, this is often used as a long-term maintenance therapy to prevent disease flares and reduce the need for glucocorticoids taken orally. Mercaptopurine is a purine analog that is structurally similar to the building blocks of your DNA and RNA. It interferes with the synthesis of nucleic acids, which are essential for the replication and function of your immune cells. So, by the inhibition of the production of these immune cells, mercaptopurine helps to modulate their immune response and reduce inflammation in the GI tract. So, like azatio, 6-mercapto is taken orally. So both of them are considered immunomodulators and are often used in combination with other medications such as glucocorticoids or aminosalicylates to achieve optimal control of IBD symptoms. Okay, these medications have a delayed onset of action and may take several weeks to months before their full therapeutic effect is observed. So we do regular monitoring of blood counts and liver functions pampaiwas ng potential side effects, no? Okay, it can cause bone marrow suppression and hepatotoxicity. So, thank you so much for listening and have a great day.